Good morning, sir, ma'am, miss. My name is Felicia Putri, and today I'm going to share what I've learned in the second week. The elasticity of tissue is due to increased blood levels of hyaluronic acid. Nasoalveolar molding, or NAM, was shown first in 1689 by Hoffman with the facial binding to narrow the cleft. NAM is performed to reduce the severity of original cleft deformity, eliminating surgical columella, and significantly improve the surgical outcome of primary repair. Appliances of NAM is divided into active and passive appliances. Lathan device and dynamic maxillary appliances, or DMA, is included in active appliances. The alteration of negative sculpting in the shape of the fit surface of the appliance allows the alveolar process to grow actively as planned by the clinician. The recommended impression material for cleft patients is rubber-based material because it is easy to manipulate, has good tear strength, the setting time can be changed, and shows the best result with least flow. Withdrawal of the impression, respiratory obstruction, foreign body aspiration, cyanosis, and difficulty with feeding tubes are the example of complications in impression making. Clinicians can do back blows, chest thrust, or finger sweeps to relieve maneuvers. The failure of tape lips segments can result in non-retentive appliances and very slow progress in closure. Nasoalveolar molding, or NAM, is a technique of pre-surgically molding the alveolus, lip, and nose in infants born with cleft lip and palate, or CLP, which restores the skeletal, cartilaginous, and soft tissue relationships. It is a non-surgical way to reshape the gums, lip, and nostrils with a plastic plate before cleft lip and palate surgery. The psychosocial problems associated with clefts are emotional turmoil in the neonatal period, poor self-esteem, and unfavorable social responses. Elastic bands with head cap, face adhesive straps, bandage over prolabium, and head cap with extraoral appliances are the example of traditional methods of pre-surgical infant orthopedics. NAM is performed in the first stage of the orthodontic management of cleft patients. Bilateral cleft lip and palate deformity is when the alar cartilage are stretched over the cleft in a flared fashion. NAM in unilateral cleft lip and palate is performed to correct the nasal tip and alar based on the affected site as well as align and approximate the intraoral segments. Meanwhile, the goals of NAM in bilateral cleft lip and palate are lengthen the columella, reposition the apex of the alar cartilage towards the tip, and to align the alveolar segments and premaxilla to form a normal maxillary arch. Clinical steps on the first visit are reinforce feeding instruction, reassure parents, lip taping, and make an impression on the intraoral cleft defect. Meanwhile, on the end of the second visit, molding plates should be delivered. The primary cleft rhinoplasty has been accepted worldwide even before the advent of nasoalveolar molding, or NAM. Deficiency in some or all the components such as skeletal base, mucosal lining, cartilaginous framework, and overlying skin. The resultant effect of primary rhinoplasty are very short columella and deviated towards the non-cleft side, downward nasal tip or diminished initial projection, lower lateral cartilage or LLC of the cleft side is depressed and concave, LLC of cleft side separates from the NC side LLC, variable kinking of in the alar margin of distortion of alar rim. The goals of primary rhinoplasty are reposition the LLC of left side to a more normal anatomic position, achieve a symmetric projection of both alar domes as well as the projection, possible correction of columella, moving the CS alar base more medially, and achieve a nasal floor symmetry. There are three methods of this rhinoplasty, which is closed tip rhinoplasty, open tip rhinoplasty, and semi-open tip rhinoplasty. So that's it from me. Thank you so much for the attention.